Okay, so I'm just here for a couple of minutes as a speaker just to welcome you to the webinar, which is looking at the management of the acute fracture of vertebral. Let me just share my screen here and get this up so I'm not talking by myself. And there we go. I hope everybody can see that now. So this is I'm really pleased to be able to introduce this webinar. We've in the Fragility Fracture Network, which I'll talk about in a bit, we've really had a focus on hip fractures in particular. And I think sometimes the vertebral fracture gets missed and is the sort of that lost fracture. And so I'm really pleased to see this webinar happening today. So my name is Lauren Beaupre. I should start with that, I guess, from the University of Alberta in Edmonton, Canada. And I am actually been engaged with the FFN for a number of years, and in fact was the scientific chair that was hoping to have a Congress last year in Toronto in person. But of course, we had to shift that to virtual because the world was a mess. But we had a very successful virtual Congress, and this work is ongoing and really trying to get to this global work that the Fragility Fracture Network wants to do. I'm currently the president-elect for the Fragility Fracture Network, and I just want to take a couple minutes here just to share the strategic vision of what the Fragility Fracture Network, why we exist and what we're aiming to do. And so we've been around since about 2011, and our vision is a world where anybody who sustains a fragility fracture achieves the optimal recovery of independent function, quality of life with no further fractures. So one of the things that the FFN really does, it's a multidisciplinary approach. It recognizes that this is not any single discipline or approach that's going to work for these patients. This has to happen from the time the patient experiences that first fracture, the management that they receive in the community or in the hospital, and then moving on to secondary fracture prevention and really connecting all these cases. So our mission then is to optimize globally the multidisciplinary management of the patient with a fragility fracture, including that secondary fracture prevention. And in fact, we also have a focus on working at national and regional levels to try and change health policy to make it easier for people to get in place. We really have a focus also on trying to reach into developing countries who are also facing surges of aging populations and that really don't have the healthcare resources to deal with what will be a fairly large burden of fragility fractures. So hopefully we can move towards improving that. So I hope that you'll consider joining the FFN. If you're not a member of the FFN, that you will seek this out and join the FFN. Our website is just going through a redevelopment, but we will be sending notices out to people, and please do come and find out more about the FFN. And what I'll talk about next is that our annual Global Congress is going to be in person this year with a perfect slogan of bouncing back. So we're going to be in Melbourne, Australia. The following year in 2023, we'll be in Oslo, Norway. And we're just going to put in the chat box, you should be able to see soon, a registration link for the Fragility Fracture Congress. I know we'd all love to go to Australia. I know that's all not practical for everyone. So we are maintaining a hybrid meeting so that you can attend virtually. So all the plenary sessions will be live streamed and recorded. So, and there would also probably some of the open paper abstracts will also be available for virtual presentation. I encourage you to submit abstracts as a virtual presenter as well. This is also available, but do come check us out. I think it'll be a great Congress. And I hope you'll join us either in Melbourne or you'll be able to join us virtually. And I'm going to stop there because I don't want to take up any more time from the important webinar, which you all signed up for. And I'm going to pass it back to Erica Dempsey, who is going to be our moderator today. Enjoy the webinar.
Thank you so much, Lauren, for that introduction to the FFN. My name is Erica Dempsey. I'm a geriatrician in Calgary, Alberta, and involved enthusiastically in our provincial fracture liaison service, which deals exclusively at this time in inpatient hip fractures. I'm really excited to be moderating our talk today on management of acute vertebral fractures in hospitalized patients, because I think that this is a huge group of patients that I'm eager to learn how to take better care of. As mentioned, for those who joined a little bit late, this webinar is being recorded. Recordings will be sent out to all registrants and as well be available on the Bone and Joint Canada website. In terms of how this webinar will be structured, we're going to start with the individual presentations and take you through the journey of a patient with an acute vertebral fracture in hospital, and have the Q&A session at the end. I'd encourage you to enter your questions in the Q&A box. That way people can interact with your question, upvote the ones that they're most interested in case we run out of time. But I will also be monitoring the chat box for questions as well. So without further ado, I'd like to get started by introducing Dr. Upinder Sahota, who will be talking to us about the management of acute vertebral fractures in the hospitalized inpatient. And because we all have the bios of our presenters, I like to introduce people with a fun fact. And Dr. Sahota is one of the few people probably in this group of all of the participants that can say that he has been on a bus trip from Toronto to Vancouver. So either he's very brave and curious, or he didn't quite understand how long Northern Ontario would be. Thank you, Dr. Sahota.
So thank you, Erica, for that kind introduction. And I'd also like to declare that that was many, many years ago, and I'm sure I would find that quite challenging now to obviously get across, but it was in more of the student days where I think it was more economical to really travel the bus, but it was a great opportunity to see the country. And really, it's my pleasure and privilege really to be with you this afternoon and sharing with you really what I hope some work that we've been doing within the UK, and perhaps some of the guidelines on how we should manage these patients. So just my disclaimer and disclosure slide just to start with, so thank you. So acute back pain is really quite a common symptom. For most sort of GPs, it's a common presentation that they will see. Most GPs will see these patients weekly, and it's estimated roughly between numbers between 231 to 295 per 1,000 patients will present with acute lower back pain. Most of these can be managed really with self-management, simple analgesia, minimal rest, and these symptoms tend to resolve. But the most important part is to reassess these patients. And clearly where these patients are failing to respond, further action should really be instigated to try and intervene and find out what's actually going on with these patients. For many patients, these back pain symptoms will actually resolve, but in a small but select few, these symptoms will continue to occur, and these patients therefore require admission to hospital. When these patients are admitted to hospital, they commonly present onto the acute medical take, and certainly within the UK, that's the first sort of process where these patients may actually present, either admitted straight onto the medical assessment unit or through the emergency department onto the medical assessment unit. And it's really very important within this patient group to ascertain both history and examination to look for anything that may suggest acute cord symptoms, because clearly the management of these types of patients is completely different to the acute vertebral fracture patient. So from the history, it's important to look for whether the patient has a history of local symptoms or referred symptoms. Do they have any radicular pain? Bowel and bladder function is really critical. Has there been a change? Has the patient having any problems? And further, from a systematic point of view, do they have any systematic symptoms that would really point towards something more of a concern? Physical examination is important and to actually to document. And I often jest with my colleagues within the hospital that on the medical wards, we're really good at examining the chest, the respiratory system and the abdomen, but really poor at examining the musculoskeletal system. So it's really important to look for neurological signs. If the patient actually has a catheter, and the trick that I often use and something that I've learned from our spinal surgeons is often give the catheter a gentle tug, And clearly for patients who have an acute cauda equina syndrome, they will not have any symptoms of feeling of the catheter. So a really useful sign that they have that good feeling of the tug, that suggests that the cauda equina is reasonably intact and is a reasonable, reassuring clinical sign that you can often use. And clearly further things looking at anal tone, anal squeeze are really important. And where you suspect an acute cauda equina lesion, then clearly urgent MRI imaging is first line investigation. For many patients, you will suspect most likely a vertebral fracture, and first line imaging would be a routine X-ray. And we would recommend, preferably if possible, a standing thoracolumbar lateral X-ray. And certainly again in the UK, our colleagues are very quick at requesting the films, but then obviously wait for this special button that says report and really struggle with these films. And the simplest approach is to start with the sacrum and then just count your way up. So sacrum here, L5, 4, 3, 2, 1, then working your way up. So usually a usual good place to guide and a usual marker. And as you can see, obviously here on this plain film, the vertebral height difference between the vertebra here and the vertebra below suggests, particularly if there's a history of an acute change in symptoms and pain localized at this site, that's a possible acute vertebral fracture. It's important to undertake some simple blood tests. Just because somebody is more elderly and somebody has a possible acute vertebral fracture, we mustn't really just assume that it's osteoporosis, and many may present with other things as well. In particular, you want to exclude the cancers within this group. So some simple blood tests we would routinely recommend: a full blood count, a biochemistry profile, a calcium, a myeloma screen, and in men, especially a PSA to exclude carcinoma of the prostate. You may consider some further tests should that clinical need and should you want to really assess that further. Vertebral osteoporotic fractures are an extremely common presentation for those admitted with acute back pain, particularly within the older age group within an acute hospital setting. And these fractures cause a huge problem with this spiral of problems and sequelae that we see. Back pain eventually resulting in spinal deformity, decreased lung capacity, impaired breathing function, loss of appetite, and subsequent further fractures, and eventually leading to increased mortality. So a significant patient with significant morbid and complicating problems. This is some work that we published now a couple of years ago, looking at the prevalence of those patients with acute vertebral fractures admitted to hospital. And as we can see, both for male and for females, this exponential rise roughly around the age of 70, 75 in all of the studies that we can see on both left and right. And this is data from our own unit. So Nottingham, we're serving a population of approximately 800,000. And this is the number of acute inpatients admitted with a vertebral fracture. And steadily the numbers have been increasing. And just this year alone, we've just gone over the 300 mark. So a significant proportion of patients presenting acutely for clinical attention. Using these same codes, so these are the codes that we can use for the acute vertebral fractures, we recently just undertaken some work looking at English hospitals at the number of patients admitted to hospital with these acute vertebral fractures. And as we can see that over a 3-year period across English hospitals, approximately just under 100,000 patients were admitted acutely to hospital. And again, of no great surprise, females accounting for the larger proportion of this patient group, and again, those aged 75 years and over. And this is really the headline figure from that data. We can see that the median age of these patients was 82 years. These patients occupied in total 1.5 million hospital bed days. Their mean length of stay within the English hospital was 14.4 days. An estimated cost of a roughly just under 6,000 per patient, but total cost 465 million. So a really extortionate number of patients, hospital bed days, and cost to a health service where we're really struggling to manage patient care on a day-to-day basis. So who are the types of patients who are admitted to hospital with acute vertebral fractures? This is, again, data from Nottingham, where we prospectively followed these patients up admitted to hospital. As we can see, consistent with the national data, mean age 79.7 years, these patients have a significant degree of cognitive impairment and a significant amount of frailty. So we can see that over 50% had a clinical frailty score of 5 or more, which is obviously scored out of 9. And again, similar in terms of length of stay here. But what's really interesting, what these numbers show here, that if we look at those patients admitted to hospital, their mean VAS score out of 10 on admission was 8.9. But even at discharge, when we thought we'd actually help manage the patient, they were in still a significant amount of pain. And at 6 months still, 5.1 out of 10 for their acute vertebral fracture. So this concept of this notion saying that these vertebral fractures heal with time and the pain goes away, we need to start changing our thinking in terms of that practice, because this isn't actually the case. And this is reflected in the mean Barthel score, which is out of 20. We can see at 6 months, these patients are really still struggling in terms of their function, where their pre-admission out of 20 was 17.2, and 6 months down the line, still 15.8, so still haven't returned back to their previous level of function. So it's important to really control the pain. And I think that's the first and foremost. I can't really stress this enough. And we see this day in, day out on our acute medical take. Patients prescribe inappropriate low-dose analgesia. So my preference is paracetamol. And then I quickly also add in a patch, and either a fentanyl or a buprenorphine patch. Because as we've shown, many patients may have a degree of cognitive impairment, and it's very easy just to apply the patch and then just to titrate the medication as you then need. Alongside this, the other important thing is to help support bowel function. So really, pain control and laxatives are critical in managing that those acute symptoms. We need to move away from this. This is what we need to stop happening. And this is what still happens in many hospitals across the UK, and even in patients that we slip through our net as well, even in Nottingham, putting patients in a bed, filling them up with morphine, and then speaking to a friendly spinal surgeon who may recommend a thoracolumbar brace, which a patient can't often tolerate, they don't know how to wear, takes weeks to arrive. So this now needs to stop. We know that every day a patient is lying in bed is a bad day. So functionally, we need to restore physical function and get them up and going as quickly as we can. In the UK, we still have the NICE guidance, which allows us to consider augmentation, and we'll be talking a little bit augmentation shortly. Olivia will give an overview of what the recommendation should be. But what I really wanted just to highlight is the UK guideline here. And what I don't propose to do is to go through every single box, because this is really quite a complex document, but really highlight something that we're really pushing towards for the acute vertebral fracture management in hospitalized patients within the UK. And really to highlight just really 3 boxes. The first box is here for those admitted to hospital, and that box is here, which is getting the acute pain optimized. So we must provide appropriate analgesia, appropriate optimization in terms of their bowel care, and trying to mobilize those patients. But actually, for those patients who are still struggling after 48 hours, that is your target. If you cannot get patients out of bed in 48 hours, you need to be doing something. But leaving them in bed, continuing as you are, is not an appropriate option. So I said for those patients then, we should be doing further urgent imaging, and where that urgent imaging confirms a surgical target, and further discussion with the spine or local interventional radiologist to consider for surgical augmentation. And again, the big challenge that we have here is that once you've made a decision for surgical augmentation, that really should be done in 72 hours. We shouldn't really be waiting another week, 2 or 3 weeks, the patient who's really struggling with pain. Again, in Nottingham, we've really pushed the boundaries. So now we're providing co-ortho geriatric management with our spine team. So as well as providing co-ortho geriatric involvement on our hip fracture patients, we also now provide a 5-day service with our spine team. And this is, I really had to show this picture because I don't think anywhere, possibly in Canada, but certainly not in Europe, you will ever find in such a close square meter a spine surgeon, a physician, a therapist, and a junior team all round together discussing patient care. And also within that, we attend the MDTs regularly so we can discuss complex patients. And we also manage the acute, the secondary prevention and the metabolic management of these bone patients too. So in summary, ladies and gentlemen, it's really important to recognize this patient group. It's really important to assess these patients. Clinical assessment is critical, but evaluation and appropriate assessment, particularly imaging, is really important. I cannot stress analgesia in terms of in terms of bowel care to really again optimize pain control, and where patients are really struggling to manage, further and appropriate imaging of the patient. Clearly, from day one, it's really important to think about where is the role of augmentation, rehabilitation, and secondary intervention, and that leads on nicely towards my co-speakers who will be presenting some of these topics. I'd like to thank you ever so much for your attention and look forward to any further questions towards the end of the session. Thank you very much again.
Thank you so much, Dr. Sahota, for just really emphasizing the vastness of this problem. When I think about 14 to 16-day length of admissions, and more importantly, that sustained dysfunction, it really paints a picture of how urgently we need to be getting better at treating these patients. So thank you for that introduction to the patient journey. I'm going to now introduce Dr. Olivier Clerc, who's going to be talking to us about vertebral augmentation. His fun fact is that he has been kind enough to share this presentation with us, despite the fact that he hasn't been getting much sleep these days due to a newborn at home. So thank you so much for making time for us.
Perfect. Thanks, Erica. All right, let's share the screen here. Perfect. And thanks, Upinder, for the very nice introduction. It's going to facilitate the introduction of this topic also. So I am a spine interventionalist. I work in Calgary, Alberta. And I have two different trainings. So one training in interventional spine and one in interventional pain management as well. So I'll be sharing with you some key facts, I believe, on vertebral augmentation. So what are the indications for vertebroplasty, the importance of doing a proper technique for this pathology to optimize results, because this is not like any other spinal interventions. And I'm going to discuss the mortality data that's already Upinder introduced. Talk about some of the papers and marked papers that have been published in the past, with an interest in two papers that were published in 2009 in the New England Journal of Medicine, and that caused lots of issue for some of our patients to get access to care. And I'm going to discuss also briefly some of the meta-analyses that are on the vertebral augmentation topic. So this is what we see very frequently, right? So this is a patient that has a thoracic fracture. Each time that the patient is breathing, basically you see that the end plates are still moving, right? So these are very extremely painful fractures. These are fractures that very frequently, when they are when the pain intensity is severe enough, patients will not improve with time. So we need to intervene on those patients. So First, when we have a patient that have a compression fractures, well, what are the treatment options that could be considered? Well, there's conservative treatments, vertebroplasty, kyphoplasty. Now there's even spine implants that we can use for in some specific cases, and surgery could be within that list as well. For those that are not familiar with vertebroplasty and kyphoplasty, what is the difference between both? So vertebroplasty, we will be injecting a polymethyl methacrylate cement within the vertebral body, so an acrylic-based medical grade cement to consolidate the fracture, versus kyphoplasty, where by definition creating a cavity within the vertebral body, frequently with a balloon, but it could be with another type of device, and then proceeding with the augmentation procedure, which is injecting the PMMA. But often and for multiple years, we heard that we should be starting with conservative treatment for a few weeks or even up to 3 months before even considering doing vertebral augmentation, and all this has changed. What we considered conservative treatment, we know that is not actually risk-free. Often we used to say that, well, that would include bed rest, pain medication, external bracing, physiotherapy. However, we know, especially in elderly, that cause multiple problems, in addition to the costs also that we just well discussed with Opinder. So those patients will have a very quickly permanent bone loss also. They can have muscle strength loss that will increase the length of their rehabilitation if we immobilize elderlies. They can have muscle contractures. They can have pressure sores also if they are hospitalized for a long period of time, which are very costly as well. Also, there's an impact on the cardiac function. We'll talk about that later on when we talk about the increased mortality in those patients that have compression fractures. So they are at risk to develop myocardial infarction. Also, with immobilization, they are at risk of DVTs, of PE, pulmonary compromise, and especially pneumonia. That also is another pathology that will increase the risk of mortality in those patients. And not only that, but we know that those patients, if we treat them conservatively, it just simply does not work. And that is true for patients that have severe enough pain, meaning that if the patient has a VAS of 5 and more, they should be treated with vertebral augmentation. Here's an example. This is a series of 100 patients out of Japan that we're treating with bracing and conservative care for 1 year, had a VAS of 7 and more, and here's the result. So only 10% reported no or very little pain at 1 year. 76% still had severe pain and required augmentation at this point. So if the patient has severe pain, and most patients that have severe pain will be hospitalized, those patients need to be treated and treated quickly. They don't improve with time. So what are the indications for vertebral augmentation? Well, this has changed also in the past. In the past, we used to say, well, we need to, fail conservative therapy and then have, T2 stir edema within the vertebral body to be able to proceed. Right now, it's switched. We changed the indication slightly. So physical examination is key. And we need advanced imaging. So what is advanced imaging? Either MRI, CT scan, or bone scan. And the key point here in a quite complex algorithm is that time is no longer an issue to select those patients and treat those patients. So we can treat those patients as soon as possible, and we should be treating them on clinical presentation, physical examination, correlation with imaging, and in some instances, they suggest also to look if there's any unfavorable factors, so at least 2 out of the 4. So progression or of height loss of the vertebral body, so if we have a prior. Severe impact on functioning, which is the majority of patients that will be hospitalized. More than 25% of height reduction, that is very frequent, also part of the definition of a compression fracture. And a kyphotic deformity also that is very frequently seen within those patients. So normally most patients that have a painful compression fracture should meet at least 2 of those criteria, and then we can proceed with the augmentation. So the cutoff is at a VAS, so a visual analog scale, so a pain from 0 to 10 of 5 and more. Positive findings on imaging, and no contraindication. So contraindication that were reduced also to virtually just the absence of any type of bloodborne or local infection. Importance of technique. So this, more than other type of spine block or spine intervention, relies heavily on technique and adequate filling of the vertebral body. So there's various type of vertebral body access that we can use to go exactly where we want to be. So we can use a transpedicular approach, parapedicular, modified inferior extrapedicular approach. So to be able to put the cement and to fill completely the vertebral body, we need to not only utilize one approach, we need to be able to move away from hardware whenever there's hardware. So technique is key. And not only that, but we know that the amount of cement injected is also very important. And that's a key, because I see often in second opinion, or I have to redo some of the work in other institutions, that the cement is just not injected enough. So, and this comes from the Swiss Spine Registry that basically really clearly states that you need to inject at least 4.5 cc per level to have optimized treatment. They followed 250 patients over 6 months, and clearly this is what they saw, that you need to fill completely the vertebral, the fracture cleft, and inject enough PMMA to reestablish the stiffness of the vertebral body and decrease adequately the pain. So here's an example. So this is a patient that we see fairly frequently, multiple compression fracture that we really had to augment multiple levels. And we thought that we injected enough cement. And again, looking more closely, there was a little bit of a small air bubble within the inferior end plate of this L3 vertebral body. And when we introduced the trocar within the inferior end plate, look how much cement we were able to inject. So we completely refill a cleft that seems to be completely occult, even on imaging. So this is why injecting and filling those clefts will really optimize the outcome of the patient. And after that, the patient had no more pain. So let's talk about the mortality data. We know that vertebral compression fractures increase the risk of mortality. There's multiple papers that have demonstrated that. Here's an example published by Lau, that vertebral compression fracturing increased by 40% the risk of have a lower survival rate of 40% at 80 years. Multiple other papers also demonstrated the same thing, and that's not only that the compression fracture increased the mortality, but that vertebral augmentation decreased the mortality. Probably the most important paper was published by my good colleague Kevin Ong a few years back, demonstrated that 1 year actually there's a decrease in mortality if you perform a balloon kyphoplasty of 55% at 1 year after the compression fracture. We know, due to two papers that were published in 2009, there has been significant decrease in volume of augmentation procedures in North America, especially in the US. So what has been the impact of this decrease in augmentation on patient care and on the mortality of those patients that did not have access to vertebral augmentation? Well, so 10 years of data was collected by Dr. Ong between 2005 and 2014. So he noted that a decline in augmentation volume of about 10% after 2009, so between 2009 and 2014. That was due to change in insurance coverage due to the two papers that were published, and also change in recommendation in some professional societies such as the AOS. So we know that the mortality is increased in those patients. So that decrease in volume led to about 75,000 patients that were at higher risk of mortality. And directly during those years in the US, over the 2 million people that were evaluated, close to 7,000 people directly died from the lack of access to vertebral augmentation. So this is a very powerful statement. So now we're moving away from using just vertebral augmentation for pain control, but now we're talking about mortality. So in the impact on mortality when we do those procedures. And why was there in that study a significant increase in mortality? Well, patients that did not have access to care had higher cardiac complication, mainly myocardial infarction, and also higher risk of pneumonia. So especially patients that have compression fracture at the thoracolumbar junction, they have decrease in typical normal lung volume, and they are prone to develop pneumonia during that painful period. So let's talk about those two papers that caused lots of harm on our field. So the first paper was published by Dr. Buchbinder, second paper by Dr. Kalmes. It's a double-blind, those are double-blind studies that evaluated vertebroplasty versus a sham treatment. Followed the patients and evaluated basically what was the impact, the benefit of proceeding with the vertebroplasty versus just the sham intervention. Both failed to demonstrate superiority of the vertebroplasty versus the sham group. The sham group was in fact only performing a periosteal block. So they were blocking basically with lidocaine up to the periosteum and then docking the trocar within the periosteum. And it is well known that if you do this, this is an active treatment because you have the medial branch nerve that is there. So the sham that they use right off the first assessment is not exactly a sham, and now we know this with retrospect. But this is why partially those two studies really failed to demonstrate superiority. Other things also that were noticed within these two papers, there was actually no physical examination that was clearly detailed. So normally, for instance, within the Buchbinder trial, they were looking at overall pain, which is, really, basically they were relying on imaging and some back pain to proceed with an augmentation, which is not what should be done. What should be done would be palpation and percussion on the spinous process, or evaluation under fluoroscopic guidance to determine that this compression fracture is the pain generator. Also, there was problem in those studies were underpowered. For instance, the Kalmes study had a target of 250 patients that needed to be enrolled, and they only enrolled 131. There was a selection bias, so so they screened 1,812 patients to get only 131 patients. Took about 4.5 years to enroll 78 patients in the Buchbinder trial. So I think it probably would take in our sites, 3 to 4 months to enroll 78 patients. And it was only procedures that were done by one single physician. There was also a high crossover rate, especially in the Kalmes study. 51% of the sham patient crossover. As we discussed, the sham group was not a true sham. It was actually an active treatment by doing a medial branch block. And we discussed about patient selection, that patients that should be treated with vertebral augmentation should have quite severe or moderate to severe amount of pain, so VAS of 5 and more. They included patients that had VAS of 3, so demonstrated statistical significance between a 3 and a 2 and a 1 and a 0 is pretty difficult also. And related to technique also within those, when we take a look on how those procedures were performed, the mean average cement injected was 2.8 cc. So with 2.8 cc, you cannot even properly train a T5 vertebral body. The lowest amount that they injected was 1.7, if I remember correctly. Here's an example here of the amount of cement that needs to be treated per level for women and for men. You see that, for instance, for a typical thoracic fracture, you should inject between 4 and 5 cc at least, and up to 8 or 9 cc for lumbar segments. Here's an example, for instance, of a case that I just did yesterday. So 2-level thoracic fracture repair. So we injected 7 cc into thoracic vertebral body. So that's the amount of cement that should be injected to have proper outcome and a complete fill of the fracture cliff. So those 2 papers were downgraded from a level 1 evidence to level 2 evidence. However, they were already out there. Unless if you pay great attention on the statistic and on all those details, you may not note that there was lots of methodological flaws. And it is very unfortunate because prior to 2009, there was 69 clinical studies that were demonstrating fantastic results for those procedures. 87% of pain relief in vertebroplasty, 92% in kyphoplasty. There was Vertus 1 that was published and was very favorable in terms of improvement in quality of life and daily activities. We hear a lot about those 2 papers. However, there's 29 level 1 and level 2 papers that are currently published that demonstrate superiority or effectiveness of vertebral augmentation. And unfortunately, you just hear about those 2 papers, and now there's Vertus 4 also that failed to demonstrate statistical significance of vertebroplasty versus sham. But others that were well performed with a true sham, meaning that only the subcutaneous soft tissues were injected and they did not perform the medial branch block, demonstrate significant difference between sham and vertebroplasty. So here's an example. You have the VAPOR trial, you have the VOPE trial also, that basically randomized control trial that demonstrated statistical significance between vertebroplasty and sham. And that lead to some of you may know the ASBMR task force that was published in 2009 that concluded that basically vertebroplasty was not superior to sham, but in their analysis, they reviewed at the end only 5 articles, and 3 of them were performed with that block that goes along the medial branch nerve. And with the other technical limitation that we just discussed. So that's the Buchbinder study, the Calme study, and the Vertus 4 study. But let's take a look what's real life data. So basically, if we take a look at Medicare patients, the EVOLVE trial that was published recently studied prospectively and followed over 12 months patients over 24 sites. There was 350 patients that were enrolled. So this is the largest collection of vertebral augmentation patient. So overall, you have a decrease of the NRS of 6.3, and this is immediate result. This is a very classic, I would say, in what we see clinically when the procedure is well performed. And not only that, but if we review the literature that include even the 2009 studies, overall, we see that, balloon kyphoplasty works great. There's a decrease in VAS of 5.1, vertebroplasty of 4.6, and non-surgical versus non-surgical management, 2.2. So in conclusion, to select, I think some of the confusion comes from patient selection in some of those papers that I think the VAS scale was too low. The technique may not have been optimized to the point that was needed to demonstrate adequate augmentation. So patient selection, we want to have a VS of 5 on 10 at least, positive physical examination, and positive advanced imaging. Technique is key. More cement is better to obtain optimal results. And just remember that we're moving away to utilize this procedure just for pain relief, but there's great evidence on mortality, and this is really a procedure that saved life and that's decreased significantly the mortality of patients after compression fractures. Thank you.
Thank you so much, Dr. Clark. I think that image that you showed at the beginning of the motion, the mobility of that fracture with breathing really spoke volumes to me. I don't think I quite had that visual understanding of what was going on to cause that pain. I'm going to now move things on to Dr. Laura John Gregorio, who's going to speak about rehabilitation for acute vertebral fractures. Her fun fact, besides the fact that she practices what she preaches and does a lot of very impressive weight-bearing activity at the gym, is that she can bake a mean pecan pie.
Thank you very much for having me today. I'm really excited that we're including sort of rehab as part of this discussion. I'd just like to acknowledge that we're on the traditional territory of the I'm on the traditional territory of the Attawandaron, Anishinaabe, and Haudenosaunee people, and the institutions that I am affiliated with are situated on the Halteman Tract, which is the land promised to the Six Nations and includes 6 miles on each side of the Grand River. So I'm framing my talk around a case study that is based on a real person who is 82. Her name is Mia Beckert, so it's not a real name. 82 years old, lives alone. She fell while carrying books, was admitted with back pain, has a history of a diagnosis of osteoporosis, has hyperkyphosis, is not currently taking osteoporosis medication by choice, was told she could not have any food until she had a consult regarding a kyphoplasty because it was found that she had a fracture, a vertebral fracture in her lumbar spine. And she also reports neck pain after lying in the hospital for a day. So what I want to do today is address some of these factors or things that she's experiencing and make tips that we can do to help her. So the first is educating on positioning and pain relief. And this can start right away. So thinking about, when she's lying down, lying when possible in the unloading position. And this can be also used for sleep. So if you have someone and they have pillows under there, especially for a lumbar fracture, a lot of movement of the lumbar spine, this position can stabilize the pelvis. So if you have some pillows under the legs, that might actually be pain relieving. So trying different sleeping strategies with supportive pillows, but this would be one example. And then another would be for the pain in her neck, because she has hyperkyphosis. Her neck, when she was lying down, was in a hyperextended position, and she's got a bit of arthritis in her neck. So doing a chin tuck exercise on a regular basis to relieve, to build strength, but also potentially relieve some of that pain would be another strategy. And the unloading position can eventually be used even as, encouraged with discharge. So doing supine lying 15 to 20 minutes a day, or 15 to 20 minutes, 2 to 4 times a day. It's thought that it unloads the spine and promotes passive extension, as well as stretching of the chest and front shoulders. So there's no evidence, no trial that has shown this, but it's something that was recommended in a consensus process that we did many years ago. And then once beyond the acute stage, we can actually add exercises in this position where we do supine presses or even back extension exercises, holding 3 to 5 seconds and repeating each 12 times. Educating a person on using cold or heat, as well as breathing exercises for if there's a concern about respiratory function. So I have a little video tip. We did a video on some breathing exercises on our YouTube channel for the Bones Labs, if you are interested. The second tip is educating on pain expectation. So as my colleagues that have also spoken is, we do know that for many people, pain and activity tolerance will get better over time, but for some it will persist. And it may actually take quite a bit of time. So educating them that pain comes from many places. It can come from the fracture, but also the surrounding musculature. And they should understand that there's going to be a time course and what that time course might be. And if it does persist, they should talk to their doctor. So they should, about getting help and then trying to get that pain under control. but that they can gradually start or resume exercise or activities of daily life, leisure, or work as the pain diminishes. So having them understand that in the initial phase, we want to try to manage the pain and then try to resume as it gets better. So having that conversation about the timeline of pain and what to expect. Tip 3 is to identify things that might affect pain chronicity. So assessing a person for pain-related psychological factors like catastrophizing, fear, anxiety, social isolation, low mood, or body image. There's some scales that could be used, like the hospital anxiety and depression scale or the pain catastrophizing scale. Educating on activity pacing or coping techniques, body awareness, spine-safe movement strategies, which I'll talk about, and movements to avoid or modify. But also choosing words carefully. So when people are told, don't bend, don't twist, don't do this, that can create fear. And it can also create activity avoidance, which can then contribute to loss of muscle mass, loss of bone mass, loss of physical functioning, which we don't want to do. So we want to find a balance between minimizing risk and making sure that we don't exacerbate pain, but also encouraging physical activity as tolerated. The other thing is, if a person, and this is maybe more in the chronic stages, but if the pain does become chronic and the person's not thriving, they should be referred for interdisciplinary pain management or medical management to try to control that pain. So helping the person understand, again, the trajectory and when they should seek help. Another tip would be to educate, this is part of that, is to educate on movement. So educating them to temporarily avoid heavy physical exertion, lifting, or activities that exacerbate pain for at least 12 weeks, and giving them examples like carrying groceries, lifting pets or children, or yard work. But then having a conversation about when to resume. And this will depend on the person in front of you, like their fracture severity, the type of fracture, symptoms, their physical capacity, what they need to do in their life. And time post-fracture and that sort of thing. But even simple tips, like if they're in the hospital, how to get out of bed. So using their arm and a log roll to get out of bed in a way that, doesn't involve flexion of the spine, which might exacerbate pain. So giving them some tips on how to move safely. Avoiding telling people, do not do this or this, but encouraging physical activity as tolerated. So having them understand, like, not all bending or twisting is bad, or not all movement is bad, but here are the types of movements that might be risky. So twisting the spine quickly over and over or all the way, so to end range of motion, bending the spine forward quickly, and I'm trying to use lay language here, quickly over and over or all the way, combined twisting and bending, and twisting and bending the spine while holding something heavy. So, a good example might be getting groceries out of a trunk. So if we're going to get groceries and you bend forward and then you twist to put it in the trunk, so bend to get it out of the cart, put it in the front, that would be an example where, maybe this is where you use your help with loading the groceries into the car rather than doing it yourself, or knowing how to bend safely. And again, this would be more in educating for future in the chronic stages, but helping them understand what types of movement might need to be modified. And this is just a thing, we have some simple tips. So bending at the hips, knees, and ankles, and not by rounding the back, holding things close to the body, or dividing weight equally in each hand, using the log roll and arm strength to get out of bed, using a step to turn to move, so trunk, knees, and toes facing the same direction, using slow and controlled movements, and also looking for resources from a national osteoporosis society. And ideally, they can see a physical or occupational therapist to get tips on safe movement, as well as a physical therapist to get some tips on an exercise program to eventually build strength and balance. And so another tip would be avoiding prolonged bed rest or sitting, as well as routine use of bracing. And this has been mentioned already. So a few days of bed rest might be indicated in the presence of severe pain, but prolonged or continuous bed rest should be limited as much as possible. The bracing literature is a bit controversial. So some of the meta-analyses that have been published suggest benefit, but there is a risk of bias. And my concern with bracing is that you have to get people to use it and use them properly, and they can result in dependence. And wearing it may then have them not actually use the muscles or learn to use the muscles to stabilize their spine. So we did a consensus process, and I'd like to acknowledge a lot of this information that I'm presenting today is a consensus process that was led by my PhD student, Matteo Pezzano. And in that consensus process, and it's under review, by the way, In that consensus process, it was a general consensus that we shouldn't recommend routine use of bracing. There might be the odd person that might benefit, but a lot of that was based on, we did a systematic review. And, so these are the findings. So yes, if you look at the data, it suggests that it favors intervention. But if you look very carefully, you see that the sample sizes are very small. And there is a lot of heterogeneity in the estimate effect. And really, there's one trial that shows a clear benefit. That group also published a subsequent trial 6 years later and essentially kind of copied the data. So it was the exact same data. The means are all the same. I'm a little bit concerned about the risk of bias just in general across the trials, but also with that particular, the 2011 publication that followed the 2004 one. So I would be hesitant based on these data to recommend bracing. Another tip would be to encourage strategies for fall and fracture prevention. So they should leave the hospital understanding that having a fracture increases their risk of future fracture, and that they should pursue strategies like exercise, nutrition, and medications to reduce that risk. Where possible, there should be a referral to an occupational therapist for a home hazard assessment and risk factor modification, or a physical therapist to do that, as well as to prescribe exercise. Exercise is one of the only single interventions that's been shown to prevent falls. And so we should recommend it for everyone with osteoporosis. We should also encourage exercise for back extensor endurance, spinal mobility, and physical functioning. And there should also be a plan to progress the exercises. So if they leave the hospital with some exercises, they should understand that there should be a commitment to doing this and continuing it and progressing it to improve strength over time. Sorry, and one more point, to also look for resources to help with that education around exercise and nutrition and medication. So we do have some available on the Osteoporosis Canada website, and we are developing some more. If anyone has ideas or things that they'd like to see, please share them with me, because we are in the process of developing new guidelines for osteoporosis management that'll be released by Osteoporosis Canada, and working on tools for that. There is some evidence that exercise can improve physical functioning after a vertebral fracture. Now, most of these studies are done in the chronic stage. So there's very few studies looking at exercise or rehab in acute patients with acute fractures. And there are not that many trials, but there's definitely data to show that it can improve mobility. I do think we do need more trials to confirm this, but in general, I think the evidence suggests that there's a rationale to do it, especially for improving mobility and physical functioning, as well as quality of life. And this is from a Cochrane systematic review that we published a few years ago. There's also, we did a systematic review of exercise for individuals with hyperkyphosis, and there's evidence that we can improve back extensor strength, back extensor endurance, kyphosis related outcomes, health related quality of life, mobility as measured by timed up and go, as well as pain. There wasn't enough evidence to suggest it would reduce falls, but many of the exercise programs that are used focus on spinal extensor muscle strengthening, as well as spinal mobility and balance and physical functioning. So basic muscle strengthening exercises, as well as some targeting the back extensors. So again, there should be a plan in place to communicate that people can benefit, even if you can't prescribe it in your context. The idea that you communicate that this is something that would benefit them, and where possible, help them navigate finding resources or a physical therapist or someone that could potentially help them with an exercise program to improve back extensor strength and balance and physical functioning. So when we talk about how do we target back extensor strengthening? So we start generally with someone who had a spine fracture. I would start them with supine lying, and this is where when they can tolerate it, I would add exercises in supine, so supine presses or supine resisted shoulder flexion exercises. But again, this may need to happen later in the chronic stages. So this is where, again, a referral to a physio once their pain has diminished would be a good idea. So starting with, supine exercises, and then progressing to exercises in prone or in seated or even in standing. And then eventually, if the person can tolerate it, progressing to more challenging exercises. So this is something, again, that would happen over time. But certainly starting the exercises in supine, because it's an unloaded position. So you're doing the exercises while the spine is unloaded. So that's sort of where we would start. But I like to think about sort of long-term, what would that look like? So again, communicating to patients that they should consider finding resources or a professional to kind of put them on a progressive exercise program. And in our consensus process, we agreed on some other therapeutic goals that would be important to consider as part of an exercise program. So one would be shoulder mobility and stabilizing the pectoral girdle. So some example exercises would be shoulder flexion, scapular retraction, wall push-ups or wall slides. Upper body strengthening exercises, and again, not in the acute stages, but once their pain is starting to diminish and they can start an exercise program. And there's certainly a lot of ways to regress and progress these exercises, so figuring out what is appropriate for the person in front of you, but eventually targeting upper body and lower body strength with strength training exercises appropriate for the person, like wall push-ups or chest press. Shoulder exercises like a shoulder press or incline chest press, standing row or lat pull down, lower body strengthening exercises like a sit to stand or a half or a full squat, a hip extension and abduction, and a step up. The balance exercises I like to categorize in a few different ways. So one being anticipatory control and dynamic stability. So thinking about heel raises or walking on toes or heels, or progressing them to something more challenging like a clock yourself app or the agility ladder, again, depending on the person's physical ability. And then with testing or training functional stability limits, having them shift their weight in all directions while standing or while standing on one foot. And then reactive control, so moving while standing on an unstable surface or catching and throwing a ball, or some people actually have a person kind of sitting and standing and give them a little external push to get them to work on reacting, or pulling on a part of the body while they're doing an activity. So thinking about exercises in each of these categories once the person is ready to start an exercise program. Nutrition is also, I'm not a dietitian, but this was some of the recommendations that came out of our consensus based on nutrition. So assess if they meet and educate on guidelines for protein, calcium, and vitamin D intake. So when weight management is, when there is a concern about weight management, poor appetite, or early satiety, consider a dietitian referral. If dysphagia is an issue, again, refer to a dietitian or speech language pathologist. Education on foods that they can use or texture modified foods. An occupational therapist referral if the functional impairments or pain that they have may actually affect their ability to buy or prepare foods. So this is something we don't often think about. You're discharging a person home, they need to be able to have food. So can we connect them with resources that can support healthy eating so that they don't lose more muscle or lose more bone? Or thinking about food access related supports. So grocery shopping delivery, meal delivery, teaching them about energy or protein dense foods if they can't prepare a lot of foods. And then also, do they have an eating environment that supports food intake and has appealing food and variety in the diet as well. So these are all part of a consensus process that we've been working on that has been submitted for publication. So I guess to summarize, the strategies are to educate on pain relief positions, pain expectation, educate on movement, cold or heat, pacing, and breathing exercises, assessing for pain-related psychological factors, educating on future fracture risk or fall risk, and assessing and educating regarding nutrition, referring to an occupational therapist or physical therapist for fall risk assessment, and a physical therapist for a progressive exercise program once they're ready to start exercise, and discouraging prolonged or continuous bed rest, prolonged sitting, or the routine use of bracing. So we have a Facebook page for our lab as well as a YouTube channel where we post interesting information. We'll be posting some more stuff as the guidelines, Osteoporosis Canada guidelines are released. And I'm thankful to be here and we'll be happy to answer questions at the end.
Thank you so much, Dr. John Gregorio. This has been really practical, and I think there's a lot of really important takeaways here. I'm going to pass this on to our final speaker, Dr. Jenny Thane, who's going to speak about what do we do now that we've expertly managed the acute fracture? How do we look forward to prevent this from happening again? Dr. Thane is a bargain hunter, although she admits to me that she's, because of circumstances, has only been to one garage sale so far this year. So hoping that things turn around and you're able to get your fill.
It would probably help if I unmuted myself. Thank you so much, Erica, for your introduction. So my name is Jenny Thane. I'm a geriatrician an internist at Western University in London, Ontario, and I do attend on our acute care of the elderly clinical teaching unit. So I'm very familiar with older adults being admitted with acute vertebral fracture, and I'm very happy to be talking today about fracture secondary prevention. Oops. Oops. Let me see what I did, sorry. Okay, so these are my disclosures. So just to put vertebral fractures into context in Canada, the Canadian Multi-Center Osteoporosis Study, which is a longitudinal cohort study focused on understanding osteoporosis in Canada, reported that nearly a quarter of men and women over the age of 50 had radiological evidence of at least one vertebral compression deformity. And we know that fracture begets fracture. So once a patient has suffered a fracture, the risk of sustaining another one goes up. So the relative risk of the subsequent fracture depends on the type of fracture which is sustained. So if you have a wrist fracture, your relative risk is 1.4. If you've had a hip fracture, your risk of sustaining a subsequent fracture is 2 times. And if you've had a vertebral fracture, the relative risk is the highest, being over 4 times more likely to sustain another fracture. And these subsequent fractures tend to happen early. So the highest risk period is within the first 1 to 2 years after the initial fracture. And this is known as imminent fracture risk. So this study by Rick Adachi and his team at McMaster University using the Ontario ISIS database demonstrates that nearly a quarter of patients who sustain a vertebral fracture go on to have a second fracture within 2 years, with median time to second fracture of 510 days. So this is less than a year and a half. And as you can see, vertebral fractures have the highest rate of second fracture as compared to other types of fragility fracture. And as many osteoporosis drugs take between 6 months to a year to become efficacious, patients can't really afford any delay in getting started with treatment for secondary fracture prevention. And what are the consequences of not getting started on treatment? Well, potentially developing this vertebral fracture cascade, as you can see in the radiograph here on the right. So once a patient develops a vertebral fracture, this increases the strain on the adjacent vertebrae, and that increases the risk of that vertebrae suffering a fracture, and so on and so forth until this cascade of recurrent fracture occurs. So what can we do as acute care health providers to try and prevent this concertina effect of multiple fractures from occurring? So Laura had her tips, so I've got my clinical pearls. So my clinical pearl number 1 is that vertebral fractures are high-risk fractures and they should be offered treatment with pharmacotherapy. So according to the Osteoporosis Canada guidelines, any patient who's experienced a vertebral fracture, a hip fracture, or more than one fragility fracture is considered to be at high risk. And these patients should all be on pharmacological therapy if that's within their goals of care. And the important thing also to know is that bone mineral density is not required if a patient has had a hip or vertebral fracture. So if you have a patient who's been admitted with an acute vertebral fracture, and you don't have a bone mineral density on file, you can't access the bone mineral density machine in the acute care, that doesn't matter. They can be started on treatment and they can have their bone mineral density after they've been discharged from hospital in the community, either for baseline testing or for monitoring of that treatment effect. Patients with acute or vertebral fracture are also at highest priority for getting started on treatment as well. So the International Osteoporosis Foundation developed pyramids to outline the strategy for prioritizing patients for osteoporosis management. And at the very top of this pyramid, you can see are hip and spine fractures because they're the ones who are at highest risk of morbidity and mortality. Similarly, the second pyramid looking at primary and secondary prevention is a higher priority than primary prevention, and patients with a new acute fracture are at the highest tip of this pyramid as well. So your acute vertebral fracture patients are going to be at the very tip of both of these pyramids, meaning that they are at the very highest priority for getting started on treatment. So this brings me to my second clinical pearl. Treatment should be started in hospital to optimize fracture risk reduction. So when we look at models of care that provide the best evidence for effective initiation of treatment, for fracture secondary prevention and osteoporosis, we have something called the 3I model, which is the basis of our fracture liaison services. So our 3 I's are identification, investigation, and initiation. So first thing is identify that the patient has had a fragility fracture and they likely have underlying osteoporosis. Second is investigating for secondary causes, as outlined by Professor Sahota. And third is initiating treatment to make sure that they have appropriate osteoporosis care. And the more I's that you have in your model, the more likely you are that the patient is going to get appropriate investigation of treatment. And it's best if we can get all 3 I's done prior to discharging the patients back to primary care. So this 3I model has the best evidence for optimal care, and we really should be aiming to get this done as soon as possible. This brings me to my clinical pearl number 3, follow guideline-directed medical therapy and consider anabolic agents. So this is a chart showing all the medications that we have available in Canada at the moment for treatment of osteoporosis. So you're probably quite familiar with the ones on the left-hand side. Bisphosphonates are often used as their first-line treatments. So you have oral alendronate and risedronate, intravenous zoledronic acid. Another anti-resorptive therapy that's commonly used as first line is denosumab. So this is a monoclonal antibody against rank ligand. And then we have our hormonally mediated treatments such as raloxifene and estrogen in the form of hormone replacement therapy. And on the right-hand side, we have our anabolic drugs, our bone formation medications, teriparatide and romosozumab. So you can see that all of these medications have evidence and are indicated for treatment of vertebral fracture. So this graph just illustrates the reduction in fracture incidence that are seen in all of the medications I've just mentioned, apart from romosozumab. So these aren't head-to-head studies, but rather a comparison illustration. So we can see that reduction in fracture incidence goes anywhere from 30% in raloxifene up to 65 to 70% with teriparatide, zoledronic acid, and denosumab in the pivotal trials. Now, anabolic drugs in particular are very effective in vertebral fracture risk reduction. So this is a pivotal trial looking at the use of teriparatide in postmenopausal women with a history of prior vertebral fracture, treated for 18 months with teriparatide as compared to placebo. And the teriparatide group had a 65% reduction in new vertebral fracture, a 77% reduction in 2 or more vertebral fractures. And not only did it reduce fracture risk, but it also reduced the severity of the fractures. In that there was an over 90% reduction in the number of patients who suffered subsequent moderate or severe fractures. So the Vero trial was a very important head-to-head study looking at the effect of risedronate versus teriparatide in osteoporotic vertebral fractures. So as I said earlier, all osteoporosis medications available can be used for vertebral fracture, but is one better than the other? So this is a double-blinded, double-dummy fracture endpoint study that enrolled postmenopausal women with established osteoporosis with at least 2 moderate or 1 severe vertebral fracture with a T-score of less than or equal to -1.5. So these are high-risk patients. And they were randomized to either daily subcutaneous teriparatide with weekly placebo tablets or weekly risedronate and placebo injections for 24 months. The primary outcome is new radiographic vertebral fractures with secondary outcomes as demonstrated here. So when it came to the results, it showed that for all the vertebral fracture endpoints, teriparatide was statistically significantly superior to risedronate. So the teriparatide group had a nearly 60% reduction in new vertebral fractures as compared to risedronate, 50% fewer new or worsened vertebral fractures, 60% fewer new moderate or severe fractures, and nearly an 80% reduction in the number of participants who developed new multiple vertebral fractures. So the efficacy of teriparatide is superior to risedronate in reducing the risk of further vertebral fractures. The other anabolic drug to consider is romosozumab. So this is a monoclonal antibody against sclerostin, and what it does is it upregulates osteoblasts and it downregulates osteoclasts. So romosozumab is given as a monthly injection for 12 months, and it can lead to quite substantial increases in bone mineral density. So these graphs are from the FRAME trial, and it demonstrates the difference in bone mineral density improvement with 1 year of romosozumab followed by 2 years of denosumab, as compared to 1 year of placebo followed by 2 years of denosumab. And as you can see, at the end of 3 years, the bone mineral density in the Romo plus denosumab group increased twice as much at both sites as compared to the placebo and denosumab group. And this increase in bone mineral density did translate into statistically significant reductions in vertebral fracture at all time points up to 36 months. So the thing to know about romosozumab is that there is a black box warning that has been issued by Health Canada for a small increase in heart disease and stroke. So in the ARCH trial, which was comparing romosozumab against alendronate, which is another first-line medication, there was a 0.9% increase in major cardiovascular and cerebrovascular adverse events in the romosozumab group. So if any of your patients have an established diagnosis of heart disease or stroke, it is not recommended that this is offered to them. So that's a whistle-stop tour of the evidence for the medications that we have available to us. But what do we do with this information, and how do we put it into practice? So the most commonly used guideline we have at the moment is the Osteoporosis Canada 2010 guidelines. And as Laura mentioned, these are currently being revised, and we're hoping that they will be published at some point this year. So the evidence has moved on since 2010. So we can look at other recently published North American guidelines to give us some guidance and direction. So the US Endocrine Society published their guidelines in 2020, and this is a bit of a busy slide, but basically summarizes their recommendations. So all patients should have calcium and vitamin D optimization, followed by risk stratification using FRAX into low, moderate, and high or very high risk. So vertebral fractures will fall into this high, very high risk category. So if you have one vertebral fracture, then you would be considered high risk. Or if you have one severe vertebral fracture or multiple vertebral fractures, then you would be considered at very high risk. And with regards to which medications to use in these different categories, high-risk patients should be offered either bisphosphonates or denosumab as first-line therapy. And if you're at very high risk, then you should be considered for those anabolic medications that we were talking about, either teriparatide or romosozumab. I have included abaloparatide here because it is in their guidelines, but this is not yet available in Canada. The Society of Obstetrics and Gynecology in Canada also recently published some guidelines in 2022. And similarly, these guidelines state that if you're intermediate or high risk, then you should be offered and treated with pharmacological therapy. And patients who are at very high risk of fracture should be considered for anabolic therapy. And again, that includes patients with acute vertebral fracture. Now, on a pragmatic level, if you recognize your patient would benefit from anabolic therapy, but you don't feel confident in prescribing them yourself, it's probably best to start them on something in hospital, like either a bisphosphonate or denosumab because of imminent fracture risk, and then referring them on to a specialist osteoporosis clinic for further consideration of anabolic therapy if that is something that they qualify for. Unfortunately, in Canada, when choosing drug treatments, provincial drug coverage does come into the equation. So Osteoporosis Canada does have a comprehensive table outlining which drugs are covered in all the provinces and territories across Canada. Unfortunately, most of the anabolic drugs are not available on provincial drug coverage, apart from exceptional access use. So they need to be funded either through private health insurance or out of pocket, which can be a significant barrier. And finally, no talk by a geriatrician is complete unless we talk about falls. So my final clinical pearl is to complete a falls risk assessment. Falls, particularly in older adults, are often multifactorial, and it's really important to identify the underlying factors and address them to mitigate future falls as necessary. And I would suggest that falls risk reduction is equally as important as providing treatment for osteoporosis in fracture risk reduction. Here is an illustration of the bread and butter of geriatric medicine, which is a comprehensive geriatric assessment aimed at completing a holistic interdisciplinary assessment. And that's an excellent framework to use when you're approaching patients with falls. So you want to address for any significant underlying medical issues that may be contributing to their falling, complete a medication review, looking for falls risk-inducing drugs. As Laura mentioned, nutrition, frailty, and sarcopenia, those are all very important factors to identify and address. You want to be able to involve your interdisciplinary team, so your allied health, occupational therapist, physiotherapist for functional environmental assessments. You may need your dietitian for nutritional concerns, social worker, etc. And after your patient has been discharged from hospital, really thinking about what further outpatient referrals would be necessary from outpatient clinic, either family medicine or internal medicine, falls clinic if you have availability, day hospital, etc. So a summary of my clinical pearls: vertebral fractures are high-risk fractures and patients should be receiving pharmacological therapy, and you don't need a bone mineral density before starting treatment. You can just start them and have bone mineral density afterwards. It's optimal to start treatment in hospital to reduce imminent fracture risk, and also because we have best evidence for this 3I model of care. Use guideline-directed medical therapy. So we have lots of drugs, all of which are indicated in patients with vertebral fracture, but particularly your patients who are at very high risk, consider anabolic therapy, although drug coverage does vary by province. And last but not least, please complete a falls assessment, because this is equally as important as considering drug therapy in fracture risk reduction. And I believe I am the last speaker, so we will be open to questions.
Fantastic. So thank you to all of our panelists for their wonderful information. I think we had so much that we've kind of taken a little bit more than our time, but hopefully if our panelists are willing to stay, we can answer any questions. I'm going to be watching the participants and the Q&A. So if you do have a question, please feel free to raise your hand, and I think I have the power to unmute you. But we do have one question in the box. Thanking everyone, in particular Dr. Opinder, but I think that was early on, for emphasizing movement. The question is, are there any specific notes to consider with a pediatric population? So this is not something that I would have ability to answer.
Yeah, I mean, apologies, but it's not, again, the age group that I look after, so I can't really comment. Maybe Laura may have some advice, possibly.
I think the strategies would probably be pretty similar. I think the challenge is like kind of then you communicating with the caregiver and problem solving strategies to do it with, because having kids do it, it's a bit more challenging. The other thing I would think about is long term, like what are the activities that the child does that they want to return to. So when we design exercise programs, we often think about like what are the things you like to do and what do you want to get better at. And I think like, so if for example, if the child plays soccer, or if the child does a certain thing, like volleyball, for example, would involve a lot of extension. So you'd want to then have some exercises that are addressing the muscles that would be involved or would support them in the activities they like to do. So those would be the things. And then again, correcting impairments that would be present. So I think it really depends on the child and what their needs are.
One of the things that I was really struck by as we went through the patient journey of their vertebral fracture was the benefits that could come from that interdisciplinary model that Opinder, you talked about having at your hospital. Are there any tips that you or anyone else has of how do we better integrate this? How do we get these patients appropriately selected and involved with interventional radiology in hospital? How do we communicate with the physiotherapy team, and how do we ensure that that secondary prevention is taken place? We've kind of got a method to do that for hip fractures, but how do we do that for vertebral fractures as well?
Yeah, I think you make a really good point, Erica. But I think, but then I think you also gave the answer as well. We've learned from hip fracture care. We really need to extrapolate to vertebral fracture care, which is what we've done in our unit. So 9-10 years ago, when I developed a lot of the hip fracture service in Nottingham, we've really moved that model of care across to vertebral fractures, and almost it's the similar problems. And I think also one of the strengths that we have as elderly care physicians, we very much work in a very MDT type of forum. So it's not really a kind of a new area to us. And it's also just bringing those skills in and trying to work within the MDT forum. So I think it's really extrapolating those skills in hip fracture care and really applying those to vertebral fractures. And that certainly works quite well. And I'm sure the same issues would apply to you and your teams as well.
Any thoughts from the other panelists? All right. Laura, I had a question for you. You had identified the importance of identifying pain-related psychological factors in patients. I think often, although I'm not necessarily looking for those, I can sometimes get a feel for that. What I struggle with is, what do I then do with those? Do you have any thoughts on that?
Oh, sorry. I was trying to flip screens and I missed it. Yeah, it's a really good question. Like it's not like we have a lot of, sort of clinical trials in this group. And, you're basically taking assessment tools that have been developed for other groups and adapting it for this group. And the same would be true for the strategies. So, using, again, depending on the issue in front of you. So like for catastrophizing, like I think CBT would be one strategy that people use, or other types of coping strategies that are designed to deal with fear or anxiety. And sometimes this might mean, a psychological referral, like, or a psychologist specializing in this sort of biopsychosocial management of pain. And there's a lot of physical therapists that do that as well. So a lot of physical therapists really do a lot of extra training to understand the biopsychosocial management of pain. So it might be a referral to someone who specializes in that and finding that person in your community to refer them to. I mean, other things would be things like, activity pacing and even breathing, because breathing then exercises kind of help you focus on mindfulness, which then might help you deal with some of that anxiety and fear. But I think it's really like, which of those items are you dealing with in the person, and then can you find support for that? So CBT would be one. Even like, I know some people will even use, like, there's online CBT tools, or there's a book called Mind Over Mood. So some people will just refer patients to those resources if they don't have an access to like a therapist. But I think it's figuring out, like, having a checklist in your toolbox of things you could do, and then having those things to refer to. I don't know if that's helpful, but.
No, I think that is very helpful. I think I've reached the questions that I really wanted to have answered. I don't see any more in the Q&A box, and I see that people are dropping off, I think, just because it's that time. I really want to thank everyone for their participation in this very informative webinar, and encourage people to get involved with the Fragility Fracture Network. Think about participating in upcoming congresses, and looking very forward to hopefully some updated Osteoporosis Canada guidelines coming soon.